Hello, everybody. Welcome to our afternoon plenary session. I'm Christy Allen from ACOG, and I have the pleasure of welcoming Congresswoman Robin Kelly and introducing her to all of you. She was kind enough to join us today and fit us into her schedule. So she's going to talk to us for a little while, and then we have a panel who is also going to discuss some of the topics she's going to bring up, as well as health policy. Congresswoman Robin Kelly has dedicated her career to public service as an advocate for Illinois families. Since being elected to serve in the 2nd Congressional District in 2013, she's worked to expand economic opportunity, community wellness, and public safety across the state. Committed to improving the health and wellness of vulnerable communities across the country, the Congresswoman serves as the Vice Chair of the Energy and Commerce Committee, the Chair of the Congressional Black Caucus Health Brain Trust, and co-chairs the Congressional Caucus on Black Women and Girls. Congresswoman Kelly has been working on maternal health issues since 2017 and introduced the Comprehensive Mamas Act during the 115th Congress. This bill would address the maternal mortality crisis by funding programs to improve data collection, address implicit and explicit biases among providers, and develop life-saving emergency protocols. The bill would also extend Medicaid postpartum coverage from 60 days to 1 year. The Medicaid postpartum extension provision was also included in the Build Back Better Act, say that 10 times fast, that passed the House last year, and key provisions of the Mamas Act were recently passed into law in the bipartisan Maternal Health Quality Improvement Act. We're grateful to Congresswoman Kelly for her leadership in Congress to improve maternal health, and we thank her for joining us at this year's National Maternal Health Innovation Symposium.
Thank you so much, Christy, and just a special shout out to ACOG because you guys were so instrumental in what we were able to do and work so wonderfully with my staff, so thank you so much. Good afternoon, everyone. I hope you're having a great conference so far, and I'm so happy to be here with you today to talk about the future of maternal health policy. As I'm sure you know, earlier this year, the CDC announced that the maternal mortality crisis is worsening and that the equity gap between Black mothers and white mothers is widening. Of course, just a few weeks ago, we saw millions of American women stripped of their right to abortion, one of the most vitally important women's health rights. We will now have forced birth in a country with one of the highest maternal mortality rates in the world. More women and girls will die as a result of this decision. It is critical that we swiftly take action to save lives and eliminate maternal health inequities. I've been working to expand women's health access to health care since coming to Congress nearly 10 years ago. As you heard, in 2017, I introduced the Mamas Act to both improve the kind of care available to women nationwide and to increase access to care for moms. I have made some progress. Earlier this year, as Christy said, my Maternal Health Quality Improvement Act, which is largely based on the Mamas Act, was signed into law by President Biden. This legislation, thank you. This legislation will improve maternal health outcomes by implementing evidence-based practices and support training programs to eliminate biases that affect care for racial and ethnic groups. Additionally, the bill will provide funding to establish rural obstetric networks to improve birth outcomes and reduce maternal morbidity in rural areas. Last year, I was successful in including the other main provision from my Mamas Act in the American Rescue Plan. This policy will allow states a 5-year option to extend postpartum Medicaid coverage from just 60 days to 12 months. 18 states and D.C. currently offer 12 months of postpartum coverage under Medicaid, and others are pursuing waivers or state-level legislation to extend coverage. And I'm proud to say Illinois was the first state. But as we know, and I know Georgia did it too with my Georgia colleagues. I was with Representative Shannon. She spoke at our hearing. But also, we also know that is not enough. The American Rescue Plan provision will run out. We need to pass mandatory permanent coverage to ensure that all women will have access to this life-saving care regardless of where they live or when they need it. I worked very hard to include this in the reconciliation plan, Unfortunately, it looks like the men negotiating the plan have left this vital women's policy out of the bill, but we will not give up. In the meantime, you can help by calling your senators and asking them to support the Mamas Act to provide 12 full months of Medicaid postpartum coverage in every state. Additionally, there are other policies I have supported to improve the future of maternal health care and eliminate racial inequities. We need innovative approaches to address this crisis. I've introduced the NIH Clinical Trial Diversity Act to ensure that we're including women of all ages, races, and ethnicities in clinical trials, and that they are appropriately represented in trials that will examine conditions or treatments for illnesses and diseases that disproportionately impact them. I have supported increasing telehealth services, expanding and diversifying our perinatal workforce, increasing access to doulas and midwives. I have supported increasing maternal mortality review committees and using the data they collect to inform evidence-based best practices. I have supported legislation and appropriations investments that would address the broader social determinants of health and ultimately alleviate health inequities. I was thrilled that CMS Administrator Brooks LaSure recently announced the Birthing Friendly Hospital designation and that Vice President Harris traveled to Illinois to announce the Biden-Harris administration new maternal health framework. As you know, this is not a simple problem, and we need multifaceted solutions to attack the problem from every side. We're at a pivotal moment in the maternal health care. Providers are being put in a terrible position, but we must do everything we can to save women's lives. We're looking into what we can do to protect women's personal health data. I am a co-sponsor of the My Body, My Data Act to protect women's data shared with third-party period tracking apps. We're trying to protect access to telehealth services and prescriptions by mail services to ensure women across the country can see providers who can help them. The work that you are doing is more important than ever. Thank you for your dedication to improving women's health. It's an honor to work alongside you on this important issue. I hope you will keep in touch with me about potential legislation solutions or even to identify problems and opportunities to improve women's health care. We like to hear when you like something that we're doing. You know, we usually don't hear that too often. And, you know, we hear when you don't like it. But even if you don't like it, we want to hear it far enough ahead of time so that we can do something about it, not at, 1 minute to 12 when it's getting ready to pass. But we want you to reach out, have a great healthcare policy advisor, and I usually have a healthcare fellow and healthcare intern because my health portfolio is so large. So please reach out to us if you have ideas. You're doing this work every day. We don't have all the ideas. We want to listen to the people doing the work. So thank you so much, and it's an honor to be with you, and I will turn things back to Christy.
Thank you so much, Representative Kelly. We appreciate your time. I am going to be joined on the stage by some wonderful panelists. We're going to talk a little bit about some of the policies that were mentioned and some of the approaches that these folks are taking with policy. Our first panelist here closest to me is Karen Mignard from the Georgia Health Policy Center. Next to her is Angie Snyder from the Georgia Health Policy Center. And then Kai Tao has joined us from the Illinois Contraceptive Access Now, or ICANN. And we're thrilled to have all of you. And I believe each of you are going to give a brief presentation, and then we're going to have some time for a conversation.
Good afternoon. I'm happy to be here, and I'm going to talk to you about the money. And so I'll just start out by saying that the Georgia Health Policy Center has done a lot of work in thinking about how to navigate the unprecedented federal funding that is available for us nationally. And I'm going to share a little bit about that with you today. The first thing I want to do is to put the funding in context. So if you look at the green bars, these are some of the funding streams that have been made available in the United States recently. If you look at the dotted lines, you can see how much, roughly in today's dollars, was spent previously on the tobacco settlement, the New Deal in the 1930s, and the money around 2008 for the Great Recession. And if you look at even the last two bars here, the rescue plan and the infrastructure plan, that money is 3 times the amount that we spent in the Great Recession in 2008. So there is a lot of money that is available. Now this, just looking at the American Rescue Plan Act, they call it ARPA, this is $1.9 trillion that is divided into 217 sections of legislation. That makes it complicated. And there are resources for different programs. And to see a little bit, these boxes, this tree diagram, looks at the different agencies and departments in the federal government and where the resources are. And you can see that a large part of the resources in that red area are going to every town, every city, every county, every state, in ways that are very flexible. These funds are being managed by the Treasury Department, and so this is important. If you looked closely into this, you would see that within HRSA, there are 14 different agencies that have responsibility for funds. Another thing that's important is that some people are saying, oh, ARPA, that's last year's news, that's over, but it's not over. The final rule wasn't released until January of 2022. The first tranche of money went to states and local governments in May of 2021, and the second tranche in May of 2022. Many jurisdictions have not decided how they want to use these resources, and there's an opportunity for you to be able to partner locally for this flexible money to support your work. In addition, some of the money is in these different federal agencies, and they have not decided yet how that money is going to be spent. So that is an important. So this money is available for communities, for programs in communities, and there's a lot of opportunity related to this. Over the weekend, I scanned the energy bill. It was, I think it's 750 pages. But part of the reason I was looking at it is I wanted to see what was there beyond tax subsidies for solar and electric cars. There's a whole section at the end that has all of these different things that are available, opportunities for grants for communities. I'm working with someone in North Carolina who has a park in her community that was built on top of a garbage dump. And they want to remediate that. And I saw several different lines in that legislation that would allow for funding to fix that kind of environmental challenge. So there are many opportunities that are part of ARPA, part of the infrastructure. Perhaps if this energy bill passes, more will be there that will be available. So what we have done is to think about how can we help people navigate this money. And we have developed a funding navigation course, And that includes a landscape analysis. And this is because of the complexity of this. And my personal mission is this money is local. And there's an opportunity for it to be spent in local ways for things that are important to people and communities. And I want to see that happen. And so this is an opportunity for you to be able to think about how this money might be used. Now, a part of our navigation training is our funding dashboard. And I'm going to share this. Now, if you have your computer and you want to look at this on your own and kind of scroll through, you can go to framingfunds.org. I'm going through this pretty fast. I just want you to get the sense of it, but you can go through on your own. The folks in the back were teasing me a little bit and said binoculars are provided at the door because, but I'm not intending for you to see everything on here. I'm intending for you to get the essence of what's here. This dashboard is divided into 5 sections, so you can look at the resources if you want to put in a particular social determinant of health. Or you can put in a more detailed example. Like one of the things that I did for another group is they wanted to know about broadband. So I put in broadband in the detailed section, and I got all the availability of current awards and state and local funding that would be eligible for broadband investment. So you could do that with topics that are of interest to you. There's also a state and local section where you can see the money that is coming to your state and also to your county, city, or town. There's also a section that allows you to look more broadly at the other money besides the Treasury money that is coming to your state. And there's also a way to be able to see the federal NOFOs, which are the federal RFPs that are kind of outside the money that's going to the states and communities. So what I want to do is just show you a little bit about this. So you can see here on this slide that there, in this beginning, there is a video. This will give you some ideas, kind of tell you some of the things that I'm telling you. So you can watch this and you can see that it's divided in these 5 different ways that I've talked about. So this is the part that's a breakdown by social determinants of health. So if you were to pick the area that has to do with transportation and built environment, then you can see that it'll start showing you what parts of the federal government are looking at this particular area and how much money there is. If you wanted to look at the detailed investments, then there's an opportunity for you to be able, let's just say we did that again, to look at this and to look at some more detail about what might be available. And then there's always this opportunity over to the right-hand side to put in your particular area of interest and see what shows up for you that might be helpful. And then if you see all of the list of the opportunities, you can click on the one you're interested in. You'll get information about what is this, how much is it, who is it for, and what's the timing of it, and there's also a link that takes you to the RFP or the NOFO. The other thing that's a part of this is if you choose a few things that you're interested in, then the tool will actually add up how much is available in those particular areas that you have chosen. You see that at the top. You also can go by state. So you choose a state, and you'll be able to see how much money is available in that state, and you'll be able to see all of the cities, counties, and towns listed and how much money went to each one of them. And you can choose. If you are in a certain place, like this one guy said, well, there's 2 counties and 5 cities that I serve. So you could click on those 2 counties and those 5 cities, and you could see the amount of money that is in that region that might be possible for someone to access, depending on what's happening in the local community. In some communities, they're really open to individual conversations. In others, they've decided already how they want to spend the money. But then you would be able to see what amount of money is available in your particular geography that you're thinking about. The other thing is that some people are asking, what money has already been sent to my state? That's not the money that's part of the Treasury Act, but other resources that have been sent to my state. So this state highlights those various federal departments and how the money has been divided up among the states. And again, you can choose a state, you can choose a social determinant. I'm going to click through, you can look at the resources, you can choose a particular opportunity. You also can look at the money that's available at the federal level. So some of this money is available in grants that you could apply for directly to different agencies. That's what this section is about. And the green bars are the ones that have not been completed yet. So you see here, there are these number of awards that are still open. You can still apply for. So this gives you an opportunity to look at those, to see what they are, and to think about how you might use those. Check out the quick tips, which give you detailed information about this, and PDFs that have the kind of information that I'm sharing with you. Now, just very quickly, I want to say our person that put a lot of work into this database, she, in this case, with this particular information, she played the role of a funding navigator. So if you were Embrace, this organization in North Carolina, she was their funding navigator. And so she found out what counties, cities, and towns were involved in the geography they served. She looked at the high level of resources that were available for those particular topics. She determined how much fit for their topics of interest. She looked at the money that had been sent to their state and how much of it was appropriate to the topic. So it was $43,000. And then she looked at the state money that had come to the state. What of that state money maybe wasn't allocated? She went beyond the database and looked into some of the state legislation and looked at some of the decisions that have been made in the state. That's what a good funding navigator would do, would delve into that. And so she found the resource that might be available at the state level. So probably in a realistic way, from the city, county, and state, there might be a significant amount of money that would be available to explore. There's also the opportunity to look at the federal NOFOs, and here you could see with the same screens which ones, these few that might be available, by entering these topics, looking at what's available, reading about when is the proposal due, what is it, who's eligible. And so what would happen in this funding navigation if you had a funding navigator? That person would bring back to you this portfolio. Here's all the different things that might be possible for you. Then you and your collaborative, you would decide which one of these opportunities do we want to pursue and who's going to do what by when. And some people are blending other resources like philanthropic or community development resources with the federal funds. So the call to action for you is think about your partners, explore these funds, contact someone who has responsibility, like someone in your county commission or your mayor's office, and begin to see how you might have a multi-sector approach to using these resources. And if you want some help, then contact Angie, because she'll be your contact for pursuing this further.
I'm waiting for my slides. Okay, thank you. All right, so as Karen mentioned, I work with Karen, and my name is Angie Snyder, and the reason why she said to contact me is because I also work with the UNC folks that are putting on this conference, and I can get you guys technical assistance on the where's the money question if you need it. So I thought I would take one other step. Karen was describing the money that's available from all of the federal inputs to deal with the pandemic, to deal with all of the challenges that folks are experiencing in their local communities now. But I thought I would also talk a little bit about the money, but also about another federal partnership opportunity, which is Medicaid. And I think a lot of you all have talked about working with your Medicaid counterparts to do a lot of great things in maternal health care. So I don't think I need to motivate you, but the reason why Medicaid is such a great policy tool to improve maternal health is because it pays for about 43% of the births in the United States. It also pays for certain groups, like rural people that live in rural areas. It pays for 50% of the births. It pays for 66% of the births to Black women and 78% of the births to women that are less than 19 years of age. So a big program, a lot of money, and a lot of support to birthing people in this country. The other great thing about Medicaid, well, good and bad, is you've probably heard you've probably heard folks say, if you've seen one state Medicaid program, you've seen one state Medicaid program. And I don't think people that do this work, until they get into it in their state and really understand their own state's program and policies, do they really realize that it is very different depending on where you are. So contextually, everybody who lives in different states, probably the individuals that are pregnant and the people that work in doing all the great work to provide services to them, they experience differences if you were in a different state. So people that were, if I was giving birth here in Illinois and I had Medicaid, I would probably get a different, I have a different experience than folks that live in my home state of Georgia. So those differences can be, they could exacerbate disparities. They could make things really confusing for people. But you can also think of the flip side of it. It's an opportunity for innovation. And it's an opportunity to target programs and to make them contextually work for where you are, what community you're in, and your individual state's needs. So these are just, if you hear people talking about it, you really do have to think locally, or at least think at the state level, because there's lots of options that you can use Medicaid. It's a great tool, but there's a lot of options that are different by state. So just a few of them, and you all probably know, many of you already know this, but who's covered? All pregnant women up to 138% of federal poverty level have to be covered under the program, but many states go much higher in terms of the FPL level of pregnant women who they cover. Some states cover immigrants, some states don't cover immigrants. And you heard Representative Kelly talk about the postpartum extension that many states are engaging in now. Up until maybe a year or two ago, all states only covered pregnant women for 60 days postpartum. But because of this enabling legislation that so many folks have passed, there's many states, like she mentioned, that are extending that time. And you can imagine, too, In states that have expanded Medicaid coverage, they're going to have a bigger impact from extending postpartum coverage than states who haven't extended Medicaid under the Affordable Care Act. So lots of different policies overlaying each other. There's also choices that states make about what services are covered, what type of providers can bill for services. Doulas and midwives, we've heard a lot of talk about that too. There's pros and cons to these things. How quality is promoted. Some states have very much instituted pay for performance, where you can kind of drive quality within the Medicaid program, and you could do that. You could aim at pregnant women or postpartum women. And then how providers are reimbursed. That's very different too. Some states pay for services. Some states have a managed care or capitated rate where they pay, and then some have more of a global payment for all of maternity care, for instance. So there's lots of options. This can get really complicated really fast. So this is just an overview of the options available, but you should always get someone that's a specialist in your Medicaid program at the table when you're talking about using Medicaid as a tool. I just want to give a big overview. You heard Representative Kelly talk about allowing states to do state plan amendments, and also that some states were doing waivers for the extension. So I just wanted to give a clarification about that. The state plan amendment, for folks that are not, that are new to the sort of Medicaid policy world, is an easier mechanism for states to use. It's sort of, if you can think about it, it's like an application that you're making to the federal government to say, I'm choosing this option, and I want you all to pay your share of the program for the state, and we're going to option that. We're going to include that option in our state plan. So it's fairly straightforward. It's already been pre-prescribed, and they've already shown the evidence that it's going to work. So it's a lot easier administratively for states when the federal government makes these an option under a state plan amendment. However, states also can do lots of innovative things with their Medicaid programs through waivers. There's just a few caveats. So you can come in with the greatest program that you've ever thought about and say, you know, I want Medicaid to pay for it. There's two things that a Medicaid administrator has to do with the government: make a case that this new program is going to be cost neutral to the federal government. So you have to show how it's going to be the federal government's going to pay the same amount for this program whether it was there or isn't. And then you also have to evaluate it and show that what you were thinking was going to happen actually happened. So it's a bit more work for states, but it allows states to be very innovative in how they deliver services in their particular state or jurisdiction. So those are usually only approved for 5 years, and you can imagine there's a lot more work for your state administrators of your Medicaid program. So I just want to make a case, just kind of like Karen did, for comprehensive system planning. There's one thing that we at the Health Policy Center, we don't advocate for particular policies, we advocate for an informed process. And we also talk about triple layer chess. So if you think about making good policy at your local level or your state level, think about it as a strategy game of, how do I align the money that Karen talked about? How do I figure out if Medicaid's the right way to pay for things? And how do I identify what I really need to do at my, wherever level that you all are working at? How do I figure out what those goals are for my program, or for women in birthing women in my jurisdiction? And so you really need to understand what's going on now, what programs are working, what's there, how is Medicaid working to enhance that, or maybe there's other opportunities to make things better. And then you need to get all the stakeholders together, and you need to hear from everyone. And then, once you've figured out what solutions you want to apply, then look to other states for what they may have done. Because like I said, it's really easy if you want to take something from someone else, but sometimes when you apply something from another context into your context, it doesn't work as well. So that's my ask of you all, to just do informed processes in your states, engage all your stakeholders, and have somebody that understands Medicaid policy so they can figure out if that's a good solution for you all. And that's my information, and I will turn it over to the next speaker.
Hi all, good afternoon. My name is Kai, and thank you so much, Angela and Karen. And let's go ahead and we're going to shift gears a little bit. We are here for a maternal health symposium, and obviously we are all on the same page when we think about the pregnant mom, the perinatal mom. We need a lot of work. There's a lot of work to be done. But I want us to kind of take a step back and think about the larger context across the lifespan, right? The average person with a uterus, I'm going to be using the word woman, but we're inclusive of anyone who has the capability to get pregnant, spends about 30 years of her life in the United States trying to thinking about pregnancy, thinking about not getting pregnant, or actively planning to not get pregnant. So I really think it's an important piece. I know Robin Kelly, and we thank her. I think she left, but she's done a lot of great work. But she touched upon this, right, when we're thinking about contraception. So I am here with Illinois Contraceptive Now, ICAN, and we believe birth control is basic health care, right? Almost 100% of people at some point in their life who are sexually active have used birth control. And for a lot of these women, they may be using birth control that has related to medical management. You know, oftentimes it could be a first line for a lot of gynecological treatment as well. So it's not just about pregnancy prevention. But we all can believe and hope that we can want to give everybody the tools and education to decide if, when, and under what circumstances to be pregnant or parent. A little data about Illinois, and I know we're from all over the United States, but I think something to think about or dig into your own state. 1 in 3 healthcare systems in Illinois are religiously affiliated. What does that mean? That means they're practicing the religious doctrine to say, I can't provide you birth control for pregnancy prevention. This should be a BFD, right? I mean, what is going on? 1 in 3 healthcare systems? We're also seeing here in Illinois, when we think about people of childbearing age, and I use, again, women from a lot of our data sets, 15 to 44, about only 1 out of 5 are getting contraceptive counseling. So we know there is a lot of room for improvement in terms of really thinking about how we normalize talking about birth control and how we routinely screen people for the contraceptive needs and desires. One more data point that I'm just going to bring up here is about contraceptive deserts. Here in Illinois, we have about 800,000 people who live in a place where they cannot get birth control for all options. That seems pretty startling. And not to mention, we have to think about the confidentiality issues that may be seen with minors. And sometimes I'm now saying minors, someone who's maybe on their parents' insurance, so under 26 years old, right? As well as intimate partner violence and reproductive coercion. Those are very real things happening. It's not the one-time headliner story. And we know all of these policies that we're talking about today really disproportionately affects Black, Indigenous, and people of color. So I'm going to go ahead and talk specifically. I think Angie did a great job of talking about the difference between waivers and SPAs. I know that language often makes most of my colleagues glaze their eyes, but I'm going to give you guys a real-life scenario of what that could look like. But before I do that, I just want to give you a brief overview of ICAN. It's a 1 minute. This is kind of ICAN on a slide, Illinois Contraceptive Access Now. As you can see, our mission is to advance contraceptive equity by de-siloing, destigmatizing, and normalizing birth control as basic health care. Okay? We feel like everyone should be screened routinely for your contraceptive needs and desires. And these are things you can take home to your health department, your health centers, to think about when you go to your health care provider, are they asking you, do you think you want children or more children someday? As a routine matter, just like we currently do with substance use or we do with mental health, right? This should be talked about. But most people go, wow, no one's really asked me this ever. And we saw some of the data around our birth rates. And you know, you can see 3 strategies here. We're going to focus on today specifically on the policy piece. The other one's more about the provider, and then the second bucket is more about our patients who we're engaging with. So what does that look like for optimizing payment and coverage? We're going to touch upon making sure that more people have coverage, and that the coverage that we do, specifically the family planning spa, is as expansive as possible and as patient-centered as possible. And again, some of those words become kind of overused, but we're going to look at what that really means. But just briefly, I want to touch upon the three other things we're doing. One is payer accountability. We talk about Medicaid, we talk about MCOs, and a lot of you guys hear about managed care organizations. They may go by different names in your state. They should be held accountable. They are being paid by the federal government to say, I'm going to take care of this covered life from the time you're born to the time you probably transition in Medicare, right? And that includes comprehensive reproductive health, family planning of all options. Is there really coverage? Are you able to get in? Do you have to drive 60 miles? These are all things we have to think about. So that's what we talk about with payer accountability. The next part is about core quality metrics. We talked about pay for performance. People follow money, right? But we're talking about how do we find RJ, reproductive justice aligned performance measures, ones that really look at contraceptive mix as well as the quality of contraception. So that we need to hear from people who are getting the care of how really is that quality. And the last thing is thinking about coverage and policy for models of care. Whether it's your pharmacist prescribing or perhaps telehealth, or is there other direct-to-consumer ways that we can bring contraception to people where they're at? So what is the Family Plan Estate Plan Amendment? The key points here, and you guys got a quick primer between a SPA and a waiver. We are now doing here in Illinois a SPA that is what we call a model family planning SPA, and I'm going to talk more about that. But 26 other states have SPAs and waivers, and I think if I was hearing this for the first time, I think, oh, that's pretty good. That's half of the United States. But so much is in the details, right? If you look at your state and SPA and look at your waiver or your family planning SPA, who is actually included? Do you have to be over 21? Does it include your household income? So then suddenly you don't qualify. Do you have to be, as I say, super, super poor, which is really not ridiculous because then nobody qualifies when you look at the federal poverty level. Other things to think about are, I'm going to go next to, what is in here in Illinois with our model SPA that's coming out at the end of this year. Essentially, if you are a single individual making less than $3,000 per month, you could qualify. And that covers all family planning and family planning related services. That sounds pretty good, right? When you think about your patients and your clients that you work with. The SPA is beautiful in that when we think about the financial piece, it's 90% covered by the feds, 10% by the state. Any family planning service is what you call 90-10. That's pretty good. Otherwise, for all the other family planning related services, it's probably more like 55, 60. It varies every state, but based on what the feds cover versus what the state. But that's still pretty good. You're sharing this cost with the federal government. And as we know, there's a lot of money out there. So what are exactly the provisions of a model family planning SPA? The first one is it's all genders. We don't care. You can be any gender. Any sexual orientation, gender identity, great. Any age, that sounds kind of crazy. Like, what? You can be any age? Exactly. If you want to be a 10-year-old and you're going to apply, no one's going to stop you. You do not need parental guardian consent. And then ultimately, the most important thing is individual. When we think about a lot of means-tested programs, when we think about your regular Medicaid, your mother-baby programs, your CHIP, right, Children's Health Insurance Plan, those are all based on income of your household. How many people in your household and how much do you all make to bring to the table? This is just about individual, so that's pretty amazing. And these are things you could start thinking about how you can do in your state. Even if you have an existing waiver, you can convert to a SPA, or you can amend your current SPA. Other things that we talk about, you're probably wondering, what does it cover? All birth control, so that covers from condoms to pills, patch, ring, depot, to IUDs, implants, and then permanent options, whether it's by tubal ligation or vasectomy. That's all covered. And then the related services. So someone could come in, and if they have burning with urination, great, we'll see you. If you have vaginal discharge, great. If you need cervical cancer screening, you're going to get your pap smear, and if you need treatment, you're going to get your Coppola or LEAP. These are all covered services. Additionally, we make sure our STIs, the screening, the treatment is all covered. We also include PrEP, right? That's the medicine we take to prevent it. And then vaccines. I think that's a pretty cool one that includes HPV vaccines and Hep A and Hep B, which are all considered in the realm of sexually transmitted vaccines. And then we also have breast screening, including ultrasounds and BRCA testing. This is what we submitted to the feds, and they're like, great. This is their chance to take advantage of this. We have a government, federal government, that really believes that this is important. Okay? And then the other piece of this is you can qualify regardless of insurance. So we hear about people, you may have third-party insurance, or it could be employer-based, or it could be off the marketplace if your state is participating. These insurances may sometimes not cover birth control, or there may be some high out-of-pocket costs still. And so someone could say, they're not going to care if you have it, you can still apply for the family planning spa. Okay? And then last things about FPPE, which I'm going to talk about next slide, but it's essentially making sure we can get care as soon as possible. As you all know, you can think of every client you've worked with. If we have delays, what happens? Right? That's why we're so keen on making sure whether it's prenatal care, as early entry to first trimester prenatal care, and same thing with family planning. If you're thinking I want birth control that day, let's get it to you without delay. So the freedom of choice, this is a federal law that means under CMS, Center for Medicaid and Medicare, it says you can get your birth control anywhere you want, regardless of your primary care medical home, your MCO network, your medical home network. You can get family planning by any Medicaid provider. I think a lot of people don't know that, and then they do know that it's not being implemented and enforced. Other considerations that are really important to allow that $3,000, if you look at the federal poverty level, it's a single person, which equates to about 283%, and that's how we land at the 3,000. But we are making sure we have parity of pregnant people. So technically, if I apply for family planning, I'm considered a household of 2 on par with pregnancy, because that's what happens when you are pregnant, okay? So that allows us a little bit more expansiveness. And then we, of course, encourage everybody, if you could get full benefits, we want you to get full Medicaid. But if you don't, then it's simply as a checkbox where then you can just say, hey, I want family planning benefits. And the last thing, of course, is confidentiality. We want to make sure people can apply without parental or guardian consent. Really quick, the FPP, and then I'm wrapping up. So a lot of you guys may have heard of medical presumptive eligibility. Someone has a positive pregnancy test, right? And they can get care right away. The same thing we're doing with family planning. I'm going to say I need birth control. I make less than $3,000 per month, and I live in Illinois. That's all you need. Doesn't matter, doesn't ask for my citizenship status either. I can get birth control covered that day. And then after the FPE, sort of the short-term coverage ends, anywhere from 31 to 60 days, depending on when you apply, I may lose coverage because ultimately I'm not a citizen. But remember, I could still apply for FPPE 2 times a year, and that covers all birth control and all those related services. Or I may end up getting full Medicaid after this presumptive eligibility, or I may just qualify for the FP SPA. So there's a lot of variations and super expansive, and that's really what we're trying to do. And this is an example of patient-centeredness. We are making sure when patients come to the health center, if they say, I think I want birth control that day, because you did such a great job of screening them, you can give them their birth control of choice without any financial barriers. I'm going to skip this slide because I think we are at time, but just something to think about, the difference between Title X, which a lot of you may have heard about, versus a family planning SPA. Ultimately, Title X is a grant funded. You run out of dollars, and it's only assigned to certain health centers. And we know there's a lot of back-end issues, and you have to get the meds specifically at the health center. While a family planning SPA has all those coverages that we talked about, and it's super expansive in that anyone who's a Medicaid payee can essentially see a patient if they have the FP SPA. All right, thank you for letting me speed talk the last minute. I'm Kai, I'm a nurse midwife, and there's my email, and feel free to contact me, and we'd love to talk to you about what you can do in your state.
So thank you to all of our panel speakers here. I so appreciate your time. I'm going to ask just one sort of basic question because I think it might be of interest to our audience. And then if anyone has questions, we have a few minutes for those, thanks to Kai's speed talking. So each of you had a unique path to working in maternal health policy, and some of you probably didn't plan to do that from the get-go. I think a lot of us wander into policy, and some of you may wish to do the same someday. And we don't all do the big acts that we know Representative Kelly talked about, the Mamas Act and the Maternal Health Quality So where, I think if each of you could just take a few seconds and talk about how you ended up here and what your recommendation would be for other maternal health professionals who are interested in moving into those spaces. We'll start with you, Karen.
Hello. Well, I started out in nursing, and as I got into my work in nursing, hospital administration, and nursing administration, I couldn't understand how the decisions about the money were made. And I was in a position of director of women's and children's services in a large tertiary health system, and I decided, you know what, I need to go back to school. I need to learn more about the money. And I kind of make a joke that I got my PhD in money. It was in healthcare financing and strategy. But in the back of my mind, I always think about the importance and the power of the things related to birth, the birth endowment and the life trajectory, and that this is a very important place for investment.
I can go ahead. Am I on? Yeah. I think the most important piece is, especially if I have any nurses out there, and I know there's a fair amount of you here, jump in. I worked at state Medicaid. I worked at our health department. Shockingly, there's very few providers who are subject matter experts within your state health department. And this isn't a knock on anyone as much as just about workforce. It historically has not been. So if at all you're thinking, well, I was a clinical schooling, kind of what you alluded to, look at those jobs, apply. They will be thrilled, and you will be really a gem for them to really say, actually, what your policy is sounds great, but it doesn't make sense, because I've been at the bedside or I've been at the clinic.
Is it on? Yeah. My pathway is similar, but not, I didn't go clinical first. I was doing street outreach, basically. I did public health work, and then same as you, Karen, and maybe you, I just wanted to help. I didn't want to help people one person at a time. I wanted to help people like globally. And so I thought that policy work was a good way to do that. And I was telling Christy and other folks earlier that I do feel like a lot of us are translators, but I feel like my translation is from the policy folks to the people on the, that are actually doing the work. And so I feel like as a policy person, I'm really a translator too. And that gives me my fulfillment, right? Instead of helping one person at a time.
Thank you all for that. It sounds like most of us sort of wander into policy. None of us started there. Any questions from the audience for any of the presenters? We've heard about a range of things, from financing, navigation dashboard, to Medicaid policy, and also to sort of the implementation of that SPA that Kai was speaking about here in Illinois. Anybody with any questions? You're getting a mic. Please hold. Thank you.
In terms of the SPA policy, is that, you may have mentioned it before, but is it only just for Illinois? Like every state has a SPA policy?
So the one I was talking about was specifically to Illinois. So every state has some kind of Medicaid plan. Some are really anemic and weak, and some are really robust. And so if you are interested in your state saying, we've got to think about other ways to improve coverage, right? Mm-hmm. Those are the two things we want. We want high quality, and we want people to have coverage. Then you would need to work with your state to look at what's available currently and look at, are there ways, and some people might be interested in saying, hey, okay, let me think about this amendment. I don't really know much about birth control or family planning, because I work at the health department and I've never thought about this, or I work at my state Medicaid. So there are ways, and some people, the waiver is another way. Illinois had a waiver for 10 years, right? But then we said, oh, well, Obamacare happened, ACA, and we thought everyone's getting universal coverage. I think we all had some hopes of that. That didn't pan out, and so now we're going back and do a permanent family planning SPA.
Okay. Okay, because I asked that question because I'm a doula, and I just think like the whole concept of a spa would be it's almost revolutionary in a way, because if you can have access to one kind of care, you can have access to another. And me as a doula being able to help families, like say you can go this way and that way to get the kind of care that they need, it's really important. So
Yeah,
that's
yeah,
what I asked about it.
great, thank you. And remember, there's a spa could be for anything. This is called family planning spa. So just like you can have a postpartum spa, and that's also what we're doing in Illinois. We talk about ARPA money, right? That helps the extension of postpartum for 12 months. We're going to do a family planning extension of postpartum, a spa for that. And maybe that's where you talk about, hey, doulas need to be at the table when we talk about what are the package under that amendment.
Thank you.
I think it shows really strongly the ability of tying policy back to what you all know is on the ground, right? What is needed. Representative Kelly talked about wanting to hear from people on the ground. They're not just saying that. We need you to inform it. I was asking a question in a session about, well, what if what they've done isn't working? How do we tell somebody that? And that's another way, but that prevents the things that don't work from being implemented. Kai was speaking about centering the patient's needs in those settings. And the legislators and the folks who put the policy through listened to that and centered that in the way it's built out. And you have the opportunity to influence that. I think we have one more minute. If there's another question, I see a hand in the back.
Hey, thank you all. I was just listening to the last part, especially thinking, I'm in North Carolina, and we also have something similar, which is great, but it always frustrates me because what it doesn't include is like pre-conception or pre-pregnancy optimization of chronic risk factors like a hemoglobin A1C or blood pressure medication or whatever it may be. And so I guess I find that it's really hard to engage people around those things. It's like less easy to engage people in policy around that maybe. I don't know. I think there's more of an opportunity now about maternal mortality and disparities because you can sort of connect to that. But is there any experience with, like, how do we get people to care more on the policy side about those topics which maybe less sexy, but really, end up, like if patients have access to evidence-based obesity treatment or chronic disease treatment, that kind of thing.
Karen was telling me that I should mention to you all, in our world, well, I don't know about you, I'll just say Karen and I, because that's pretty much all we do is policy stuff. I didn't say this before, but the window is wide open because of all the work that everyone has done to raise awareness about maternal mortality and infant mortality. And so this is the time to bring your ideas forward, because if they get to the right people and you've got the right group of people together, you guys can do great things. So the thing that you said is the exact same thing that I heard when we were getting a group of people together in Georgia. They basically said, the clinician said, you don't make women healthier when they get pregnant. They only, whatever they come to the table with when they're pregnant, it's not going to get better. So it speaks to what you're saying. Preconception care is really important, and it's not like the folks didn't, get that. I mean, I think that sentiment was shared, but what they ended up doing in Georgia was doing the postpartum extension. But really, they need to go further upstream and deal with some of the social determinants. And I'm sure some of you all are doing that, trying to get all women of childbearing age healthy. And some folks in some states that have Medicaid expansion, you have the opportunity to create programs to do that very thing. And if you guys do great and prove that it works really well, maybe some of the states that haven't done that would think that that might be a good option for them too. So I say go forth and talk to folks about it and see what you can get.
Well, it sounds like we're at time. We thank you all for your time and attention, and especially to our speakers, Karen, Angie, and Kai. Thank you so much for talking about your work and engaging in the space, and for all you're doing for people trying to be pregnant, parent, give birth, or not parent and give birth. Take care.